disease, or PD, affects nearly 1 million people in the United States and is projected to rise to 1.2 million by 2030. It is the second most common neurodegenerative disease following Alzheimer's disease, and there are nearly 90,000 new cases diagnosed in the U.S. each year. Hello, and welcome to the Comfort Connections podcast. In this episode, Strategies for Implementing Person-Centered Parkinson's Care, we are joined by Melissa Morante. She's co-owner and chief marketing officer of ComForCare Home Care, a private duty and home care agency serving South Florida. She will provide insight into Parkinson's disease and delve into the latest approaches, best practices, and innovative techniques that empower aging services professionals to help prioritize the unique needs, preferences, and quality of life of those living with Parkinson's. This session is moderated by McKnight's News. Let's listen in.
Melissa Morante sits on the board of directors for the Mind Music Movement Foundation, helping bring education and support to those living with neurodegenerative diseases in South Florida. She facilitates 8 support groups each month for those living with Parkinson's disease and their family caregivers throughout Palm Beach County and the Treasure Coast. She is also a former board member of the American Parkinson Disease Association South Florida chapter, support group facilitator, and certified group fitness instructor with a specialty in senior fitness and Parkinson's exercise. Melissa is responsible for training caregivers on both motor and non-motor symptoms, disease progression, and the importance of timing and food when taking Parkinson's medications. She has a unique understanding of the disease and how to work with those living with Parkinson's. So, Melissa, I don't think we can have a better expert on Parkinson's today. You're going to tell us how to better care for these patients. Is that right?
It is. Thank you so much, Liza. And thanks for having me this morning. I am very passionate about Parkinson's disease. Unfortunately, Parkinson's is still a distant second from Alzheimer's disease. And while we have made tremendous progress in education and awareness, there is still a lot to be done. And so if we can just have one person get diagnosed sooner than they otherwise may have, then we're doing everything we're supposed to be doing. So this morning we will take a look, we'll define Parkinson's disease, talk a little bit about the progression, what you may see when you're working with somebody who is living with Parkinson's. We'll talk about some strategies and how to care for those folks, and then really dig into how a person-centered approach can improve the quality of care for those who are living with Parkinson's disease. All right. So typically when I do this presentation, we do a little quiz with my audience, but that's not possible today. So I'm going to blow through these pretty quickly. A lot of them you may recognize, but these are some famous folks who lived or are living with Parkinson's disease. So everybody knows who this is. Muhammad Ali, obviously the face of Parkinson's disease. Michael J. Fox, he has done such tremendous work in raising awareness and money, quite frankly, for research. Neil Diamond, George Bush, Alan Alda. Some folks may not know who this is. His name is Brian Grant. He is a former NBA player, used to play for the Miami Heat, diagnosed at age 33. So he is a young onset Parkinson's patient and created his own foundation, the Brian Grant Foundation. Offers wonderful exercise programs and information and resources for those living with the disease. Janet Reno, Ozzy Osbourne, and of course, Linda Ronstadt. All right. So what is Parkinson's disease? Parkinson's disease is what we call a movement disorder. It is progressive. There is no cure. What happens in Parkinson's disease is there is a lack of dopamine in the brain, which dopamine is the hormone that is responsible for movement. And so typically what you'll see, I'm not going to go in order here on this slide, but typically what you see with Parkinson's disease, not everybody has tremor. but some folks do. So you'll notice a tremor. It's important to know not everybody with Parkinson's has tremor, and not everybody with tremor has Parkinson's. So there is something called essential tremor. Some folks experience stiffness and rigidity. You will see slowness of movement. It's called bradykinesia. You'll also typically see in the early stages, one arm will not swing when the person is walking. Parkinson's typically affects one side in the beginning, and then as the disease progresses, it will affect the other side. You'll see sort of this tilted trunk. They call it the Parkinson's mask. So it looks like the person is not smiling and there's kind of no emotion. That is simply because the muscles in the face are not able to move the way they used to. And then, of course, the gait. So narrow gait, shuffling, and very short steps. Onset is typically between 50 and 60. 10% of those living with Parkinson's disease are young onset patients. I will say, in my experience here, I am finding folks that are being diagnosed later, 70s, even early 80s. And I think, quite frankly, people are living longer, right? We know that. And so they just aren't going to the doctor, and those symptoms are happening later in life. The other thing that's important to know with Parkinson's, we talk about symptoms in terms of motor symptoms and non-motor symptoms. The non-motor symptoms are what happen first, and they typically happen 10 to even 20 years before the motor symptoms. And so by the time folks are diagnosed, because it's the motor symptoms that make people question what's going on and think, oh, yikes, I might need to go see a neurologist, they've already had the disease. So the non-motor symptoms are, the things you don't see. So constipation is a huge problem. Anxiety, depression, urinary incontinence, orthostatic hypotension, so getting up and feeling dizzy, small handwriting, the decrease in the ability to smell. People lose their sense of smell. And all of those things happen first. And it isn't until somebody starts to either fall, somebody notices their gait is off, their balance is off, maybe that arm isn't swinging, they develop a tremor, and then they say, something's up. I need to go see a neurologist. The statistics, they're increasing. This is a fairly new statistic, 90,000 new diagnoses each year. It was 60,000. You could look at this two ways, in my opinion, right? One is, yikes, now more and more people are being diagnosed with this disease. I actually look at it as it's a positive because this means people are aware. And so they are going to their doctor and they are getting diagnosed, which means now they can do all the things they need to do to live with this disease, manage the symptoms, and quite frankly, live a pretty good quality of life. You can live independently for a very long time with Parkinson's disease if you do the things that you are supposed to do. Parkinson's disease does not kill you. You do not die from Parkinson's. You die from complications of Parkinson's, but Parkinson's disease in and of itself does not kill you. So when we look at Parkinson's disease, Parkinsonism, think of that as ice cream, and then there's different flavors of ice cream. Idiopathic or typical or classic Parkinson's disease is 85% of the Parkinsonisms that are out there. It's the most common. It's typically what you will see. All the things I just described, that describes typical Parkinson's disease. There are other conditions that are caused by a lack of dopamine that look similar to Parkinson's disease, but they're not. We don't have time to go into great detail on those things, on those conditions. Some of them progress much faster than typical Parkinson's disease. I have met people who have been living with Parkinson's disease for 40 years. These other conditions progress typically faster. So multiple system atrophy, corticobasal degeneration, progressive supranuclear palsy. We'll talk briefly about dementia with Lewy bodies in a little while. And then there's some atypical Parkinsonisms. But those are the different flavors of Parkinsonism. So people always want to know, they always say, well, what causes it? Well, I mean, look, the truth is if we knew what caused it, then we'd have a cure. So we know it's a lack of dopamine, but we talk about this in terms of risk factors. So what are the things that increase one's risk of developing Parkinson's disease? Unfortunately, men are twice as likely than women to develop Parkinson's. Interestingly enough, the opposite is true of Alzheimer's disease. Women are twice as likely than men to develop Alzheimer's disease. We talk a lot about environmental risk factors. Everybody has seen those commercials on TV. Agent Orange, folks who have come back from war with the burning fields. We talk about traumatic brain injury. So there's an interesting story about Muhammad Ali. Everybody thinks that he developed Parkinson's disease because of his repeated brain injury. And of course, that didn't help his situation. But his doctor actually did come out and say when he was first on the circuit, he didn't have any money and he was staying in these, flea bag motels, and he had a horrible fear of insects. And so they would come into his room and spray insecticides and bug sprays and chemicals. And they believe that that is likely the cause initially. And then, of course, the repeated brain injury did not help the situation. There are genetic markers. There are many genetic markers. It does not mean that you are definitely going to get it. It just means that you can carry the gene, and that does increase your risk. And increase your risk by how much? We don't know, right? 50%, 5%, 0.05%, nobody knows. But there is genetic testing that you can do to see if you are a carrier of one of those genetic markers. And then, like I said earlier, age is obviously a risk factor for any chronic illness. Everybody's living longer, and so we're all susceptible to develop some chronic illness as we age. So it's not very scientific how doctors diagnose Parkinson's disease. There is no blood test. Typically what happens is the motor symptoms start to appear. Somebody says, I probably should go see a neurologist. Really, who they should be seeing is a movement disorder specialist. That is a subspecialty of neurology. They have 2 additional years of training, and they really are experts in Parkinson's disease and other movement disorders. And so you go in, you see your movement disorder specialist. They have you do a series of movements, tapping your fingers to your thumb, raising your knee and lowering your hand, tapping your foot, getting up, walking down the hall, coming back, turning around, coming back. And then based on how you score on all of those exercises or movements, the doctor then determines whether or not you have Parkinson's disease. It's very subjective. There is no objective test. There is a brain scan. It's called a DAT scan. It is an imaging technology. They put a small amount of a radioactive drug to see how much dopamine is available in a person's brain. It's similar to an MRI, but essentially what it tells you is if there is less dopamine than there should be. This DAT scan can confirm a diagnosis, but it does not diagnose Parkinson's disease. There actually is a new spinal fluid test that looks at clumps of a protein called alpha-synuclein. And people who have sort of abnormal clumps of alpha-synuclein could be at risk of developing Parkinson's disease. Again, not very scientific, unfortunately. The other thing that happens is the movement disorder specialist says, okay, we're going to treat you as if you have Parkinson's disease. They typically prescribe a drug called Sinemet. We're going to get into that in a minute. If that medication does not work, the person typically has something else. So if the Sinemet works, then that person has typical Parkinson's disease. If not, they probably have one of those other conditions that I mentioned earlier. So I mentioned there's no cure. However, there are things that people do to treat and manage the symptoms. Medications. People with Parkinson's are typically on many medications, and we're going to get into some of those details in a second. Medications are great. They help manage your symptoms. They do everything with Parkinson's is a trade-off, so that, of course, they come with side effects. Sinemet, like I mentioned, carbidopa, levodopa, it's been the gold standard for 50 plus years. That's still what movement disorder specialists are prescribing. Exercise is the only scientifically proven method to slow the progression of the disease. So again, medications will manage the symptoms. Exercise is the only thing that will slow the progression of the disease. There are 2 surgical treatment options. Again, trade-offs, right? With both. We'll get into that in a little bit. Surgical treatment options are not for everybody. Typically, they're used when people are not having great results with their medication. So let's talk about the medication, because the medication is critical to managing the symptoms, and how you take your medication is critical. So I mentioned that Parkinson's disease is a result of a lack of dopamine in the brain. There's 2 types of medications. So one replenishes the dopamine. The other tricks your brain into thinking that it is getting Sinemet or dopamine. So the most potent medication is levodopa. Plain levodopa by itself causes nausea and vomiting. And so what they did many years ago is they combined levodopa with carbidopa to prevent that side effect. If you ask anybody who has Parkinson's disease, you will likely hear them say, I'm on carbidopa, levodopa, or Sinemet. Sinemet has a half-life, and so the timing of taking this medication is critical. So by way of example, let's say that the doctor prescribes the medication and my schedule is to take the medication at 8 a.m., 12 p.m., 4 p.m., and 8 p.m. I take my medication at 8 in the morning, takes about an hour to kick in. Now it's 9, I'm feeling good, I'm up, showering, I'm getting dressed, I'm eating breakfast, and I'm getting ready to start my day. Well, now it's 10 o'clock and half the medication is gone, right? And I'm not due for my next dose until 12 o'clock. So the timing of that next dose is critical because my symptoms may start to return between 10 and 12. If I miss that dose at 12 o'clock, it's going to take even longer for me to feel better. And so my symptoms will return and I'm not going to feel as great for the rest of the day. So the timing of when you take your medication is critical. Now, like everything with Parkinson's, there are trade-offs. So when you are on carbidopa, levodopa for many years, you start to experience what's called dyskinesias. So if you have seen Michael J. Fox recently, when you see him with those involuntary movements, sort of like his shoulders kind of move forward and back, people sort of cross and uncross their legs, Those are dyskinesias. They're involuntary movements. Tremor is more sort of rhythmic. The trade-off of being on carbidopa-levodopa for a very long time is dyskinesias. So if people are diagnosed and their symptoms are not so disruptive and they may be on the younger side, doctors will often prescribe what's called a dopamine agonist. They're not as potent as carbidopa-levodopa. These are the medications that trick your brain into thinking that it is getting dopamine. It kind of mimics, what the dopamine does. The other medications that are available. So I mentioned, right, between 10 and 12, symptoms may start to reappear. Well, if it's 11 o'clock and you're ready to go to your exercise class, but your symptoms are starting to return, that's going to prove to be somewhat difficult. So there are new medications called rescue medications, and they're like little boosts of dopamine to kind of get you over the hump, to get you to your next dose. They come in two formats. What is called Apokin. It looks like an EpiPen and it works exactly the same way. You kind of jab it into your leg. The medication goes right into your bloodstream, takes about 10 minutes, and then you are ready to go. And that will get you through to your next dose. The other rescue medication is called Inbrija. That is an inhaled form of levodopa, kind of works like an asthma inhaler. And that too will get you through to that next dose. There is another medication. It's called Duopa. Think of this like an insulin pump for diabetes. There's a tube that's placed into the stomach. You wear like a little pouch all day. The medication comes in a gel pack, and it is a steady stream of carbidopa-levodopa. And so it helps manage those on-off periods because you're getting that steady stream of medication. Oftentimes when people use Duopa, they no longer have to swallow pills. You can supplement if you need to. I believe it's twice a day. But oftentimes with that, you really don't have to swallow any carbidopa-levodopa pills. Again, trade-off. I know some folks who have had the Duopa pump and have had to have it removed because of infections with the tube. So, but I've met other people who have had it. One person I met was in the clinical trial for it, still using it, and loves it, swears it's changed his life, and couldn't imagine doing it any other way. So everybody's really quite different. I always say when you've met one person with Parkinson's, you've met one person with Parkinson's. Surgical treatment options. So this is brain surgery. Deep brain stimulation, very invasive, but you can turn it off. You can reprogram. You can move leads if you need to. So the way deep brain stimulation works is a brain surgeon works closely with a movement disorder specialist. They drill 2 holes in your skull, and they place leads in the part of the brain that controls the symptoms that are disruptive to the patient's life. It used to be that deep brain stimulation was really used for tremor. But what they found was that depending upon where you put the leads, you could also help other symptoms. So I actually know somebody who had deep brain stimulation. He didn't have any tremor. His biggest problem was stiffness and rigidity, very debilitating stiffness and rigidity. And he had deep brain stimulation, and that changed his life. And so, like I said, they drill the holes, they put the leads in. About 3 weeks later, you go back, they put in the battery. It's kind of like a pacemaker. I'm sorry. Like a pacemaker. And then the movement disorder specialist programs that and can alter according to, kind of switch it up based on how your disease is progressing and if your symptoms are returning. A lot of people think when you have deep brain stimulation, you can come off your meds. That is not true. Typically, what happens is your meds are reduced about 50%. Again, everybody's different, but there is a reduction in medication. People don't come off of it completely. The other surgical treatment option is what we call MRI-focused ultrasound. Much less invasive than deep brain stimulation. However, this surgical treatment option essentially is burning a stroke in the brain. And so while it is much less invasive, it is permanent. Deep brain stimulation, again, you can turn it off, you can move the leads, you can switch up the programming. MRI-focused ultrasound, you better hope they get it right the first time because it is permanent. So again, everything's a trade-off. Okay. My favorite topic, exercise. I'll talk about this all day long. I said it again. I can't say it enough. Exercise is the only scientifically proven way to slow the progression. Now, there are specific exercise programs that are designed for people with Parkinson's disease. Some of you may have heard of Rocksteady Boxing. It is a boxing class. You are not hitting people. You're hitting bags. So those small, I forget what they're called, but those small bags, that you pound really fast. And then there's those big, giant, heavy bags that hang. There is a cognitive component too, which is really fantastic. So what happens in Rocksteady Boxing is the instructor will call out series of numbers, and each number is assigned a movement with your hands. And so you have to remember the pattern and then repeat the pattern with your boxing. It is a wonderful, wonderful program. There's a Dance for PD program, which is also great because we know the benefits of music for any neurological condition. But the truth of the matter is, any exercise counts, right? We just need people to keep moving. So Tai Chi is great for balance. Yoga is great for flexibility. Swimming is a wonderful exercise for people with Parkinson's because it's really, really hard to fall in a pool. And so for people who are great fall risks, water exercise is very safe. I love when I ask people, are you exercising? And they tell me, well, I'm going to physical therapy 3 days a week. Physical therapy is not exercise. They're two different things. And the truth is you need all of this as part of your therapies and treatment options when you're living with Parkinson's disease. So for those who don't know, physical therapy is designed to restore movement. You have surgery, you have taken a fall, you go to physical therapy to restore the movement. Occupational therapy, that is a therapy to help with functional movements. So getting on and off the toilet, getting in and out of the car, putting on your shoes, buttoning your shirt, emptying the dishwasher. That's occupational therapy. Speech therapy, I hear all the time. I heard it the other day. I was meeting with somebody. I don't need speech therapy yet because my voice sounds fine. Well, yes, your voice does sound fine, but there's a couple things to remember here. One, it's much easier to maintain what you have than to fix what's declined. And so everything with Parkinson's disease, it's important to remember this. Everything with Parkinson's disease gets slower and smaller. And that includes I don't know the exact number, but call it 120-ish muscles in your throat. So not only does speech therapy help with pronunciation and volume, but it helps with things like swallowing, drooling, all of which become challenges as the disease progresses. And so starting speech therapy upon diagnosis is a great idea because it will delay some of those swallowing and drooling challenges, and it will also help maintain your pronunciation and your volume with speech. My second favorite topic, diet, nutrition. So, I mean, this applies to people with Parkinson's disease, but quite frankly, this applies to anybody, right? Everybody should be sort of using the 80-20 rule, in my opinion, right? Making good choices 80% of the time. But specifically for people with Parkinson's disease, eating the right foods will really help optimize your medications. It'll help keep your bones strong. It'll help with constipation, which is a huge problem. It'll help with weight loss. If you're exercising the way you should be exercising, you need the fuel to keep going. So we want to make sure we're fueling our bodies with good foods. So things that are important to remember, and I don't think any of this will come as a surprise to anybody on this call. Obviously, we want folks to drink enough water and eat foods that are rich in fiber. That will help with all of the constipation. So whole grains, fruits, beans, green leafy vegetables. Again, people with Parkinson's take a lot of medication. So we really want to make sure they're taking those medications with a full glass of water. We really should be limiting sugar. It's very, very inflammatory. And so the goal here is to eat more anti-inflammatory foods with antioxidant properties, and less of the processed bad stuff, right? Alcohol should really be in moderation and with your doctor's approval. Again, people with Parkinson's are on a lot of medications, and so drinking alcohol, right? We just want to make sure that that's okay and safe. People with Parkinson's typically have trouble sleeping. They are often fatigued, and so they sleep oftentimes during the day. They nap, and so sleeping at night becomes a problem. So limiting caffeine in the afternoon is a good thing to remember. A lot of doctors, neurologists and movement disorder specialists that I talk to here in my area talk a lot about the MIND diet. That is a cross between the Mediterranean diet and the DASH diet, Dietary Approach for Stopping Hypertension. So again, everyone's familiar with the Mediterranean diet, right? So it's things like healthy fatty fishes. Those things help maintain bone health. Mackerel, salmon, tuna. Eggs are a great source of protein. I talked about berries, lots of colors. Limited dairy, only because dairy is also very inflammatory. And so we really want to make sure that we're limiting those inflammatory foods. There used to be a lot of talk about watching your protein intake at the same time you take your medication. I've heard recently that isn't really as big of a concern anymore. Doctors used to say the eating protein would impact the absorption of the medication, the Cinemet. I was with a movement disorder specialist a couple weeks ago, and he said, it's not really as big of a concern. It's more important that you're taking your medication on time. And making sure that if you are getting nauseous when you take your medication, that you're taking it with some food. So timing is more critical than what you're taking it with. If somebody has tremor, eating can present some challenges down the road. There are things out there like weighted utensils. You can wear a bracelet that helps weigh your wrist down and your hand down to help with tremor. As swallowing becomes a challenge, it may be that we need to cut food into teeny tiny pieces. It may be that at some point in end stage, foods will need to be pureed. Liquids may need to be thickened. Straws, not a great idea for people with Parkinson's disease. liquid comes up too fast, they can choke. So believe it or not, we don't typically recommend using a straw for people with Parkinson's disease. So activities of daily living. Look, moving around becomes harder as the disease progresses. Exercise will help with that, of course. Sometimes people with Parkinson's disease will experience what we call freezing, and it is exactly what you think it is. Their feet are quite literally frozen to the floor, and they can't move. It typically happens when folks walk through a doorway, although it can happen other times. It's quite easy to get somebody to unfreeze. So one of the things you can do is snap your fingers kind of like a metronome and say, okay, Mary, on the count of 3, we're going to walk. And you count 3 and they walk. That will help. The other thing you can do is obviously you want to stand near them, especially if they're a fall risk. But if they shift their weight ever so slightly from one foot to the other, that can also help unfreeze. And then the other thing you can do is throw something on the floor, a pen or a book or something, and say, I need you to step over this pen, or I need you to step over this book. And that will help unfreeze. In terms of home safety, again, important for people living with Parkinson's disease, but the truth is important for any senior that's, still living independently. Be mindful of all of the fall risks that we're already considering. So clutter, that's bad news. We want to make sure there's no clutter. We want to make sure that there's enough room to walk, through and around furniture. Make sure there's enough lighting. People should be wearing rubber-soled shoes in their house. Here in Florida, there's ceramic tile everywhere. So walking on ceramic tile with socks is just a recipe for disaster. Throw rugs, yes, they're beautiful, but they're dangerous. So either tack them down or better yet, get rid of them. Nobody with Parkinson's disease should ever be on a step stool. So things you use frequently in the kitchen, you may need to reorganize your kitchen. You may need to move those things down lower so you can reach them. Steps, really, really, really need to be careful with steps. Certainly make sure there's railings. They still have those chairs that go up the railings. In terms of the bathroom, obviously grab bars, obviously no slip strips. This one might not be so intuitive, but imagine a person with Parkinson's disease who is experiencing orthostatic hypotension, and they're using a bar of soap, and that bar of soap drops in the shower. Well, now they're going to bend down to pick up that slippery bar of soap. They may get dizzy when they stand up, so they may fall in the shower, hit their head, and then who knows what happens after that. Buy soap in a pump. Keep it on the shelf, and then just this way, nothing falls. Nobody has to bend down and pick it up. A shower chair is a great idea when folks are no longer able to stand in the shower by themselves. We've pretty much exhausted mealtime. Again, healthy meals, soft, small foods as the disease progresses. Timing of the medication is critical. If folks are getting nauseous, make sure they take it with food. Getting dressed will become a challenge as the disease progresses. Obviously, folks should be sitting down when they put their pants on. Non-skid socks are a great idea instead of slippers. Allow plenty of time. So if you're caring for somebody with Parkinson's disease, the morning time is the hardest time because typically they've gone all night without their medications. And so it really does take quite a bit of time to get going. So the recommendation is take your medications, let those medications kick in, and then get up and get dressed and start your day. But slip-on shoes without ties, that's helpful. They make things now that you can put in your socks to help you pull up your socks. Shirts that don't have buttons or zippers as those things become more challenging are a great option. So it's just being mindful of how to help folks still remain independent, but putting some, things in place that just make those things a little bit easier. All right. So all the things I just described are activities of daily living, and those physical needs are pretty easy to identify, right? We know if somebody with Parkinson's disease is, if their gait and balance is off. So they're definitely going to need standby assistance, and they're definitely going to need assistance getting in and out of the shower. Physical needs are very easy to identify when we're caring for somebody. Emotional needs, not so much, right? And so good caregiving really takes into account both of those things. I'm going to skip this slide. So when we talk about the emotional needs, right, we really want to dig in to who this person is, right? And this goes beyond things like, what did you do for your job? How many kids did you have? Where did you live? Right? It really digs into what made you so proud, right? What are your values? What are your traditions? Did you attend temple and church on a regular basis? Were you in the military? What are your greatest successes? We really, really want to, we call it social history or life story. And then take all of those things, right? And you can get that information in lots of ways. I mean, you can certainly interview the person living with the disease. Look, only 50% of people with Parkinson's disease will develop Parkinson's disease dementia. And so their faculties are there. So they'll remember, ask them questions, really dig in, have them show you old pictures, have them share memorabilia, ask family members, ask neighbors, ask friends. I'll give you an example, my own personal example. When I was a kid, every Sunday, my father would make French toast with my sister and I and my mom. And we would play music. I'm dating myself on 8 tracks. And it was Harry Chapin, Billy Joel, Jim Croce. And so fast forward, right? If I'm living with Parkinson's disease and I'm thinking back through the memories that are significant to me, if I smell French toast and I hear Harry Chapin, I am instantly 8 years old, sitting at my kitchen table, and I am as happy as can be. And so it's things like that that really can impact and improve the quality of care. Another thing, right? Scents are so important and triggering, I guess, for lack of a better word. If I smell Shalimar perfume, my mom wore Shalimar perfume every time my parents used to go out. When I smell that, I'm instantly transported right back to being a kid. So those are the things that you really want to dig into and understand so that you can create what we call meaningful activities. So we talk about it here. Activities of daily living help people live, right? Meaningful activities give people a life worth living, right? So we take that life story or that social history and all of the things that made somebody who they are, and we couple that with where they are in the progression of the disease. And that's how we develop a plan of care. Now, the X's on this chart are on purpose. I did not forget to put them in. And that is because the breakdown of these things is different for everybody. So somebody who is earlier on in the progression of the disease may not need as much help with activities of daily living, right? They may just need more meaningful activities. Look, safety and security is always the top priority. But the other things are different, and it really depends on the person and where they are in the disease. And so when we talk about that person-centered plan of care, I mentioned it earlier, right? The smell of French toast, the smell of the perfume, the hearing of the music, right? Those are the things that really can help connect to someone's life story. Okay. So you have a toolkit, right? You need some tools to make this happen. You want to make sure those tools help you address any challenges that are presented. You're going to have to make adjustments. Every day is different, right? We want to minimize the risks. And of course, we want to maximize the opportunities. So again, we're running out of time, so I don't have time to go into all of these things. But again, look, check yourself, right? We call it give yourself a checkup from the neck up, right? So your reaction to them is the only thing you can control, right? Listen to them, right? Show respect. You need to be where they are. Positive emotions are really important. Providing meaningful activities, right? That's important. We want to, this isn't just about making sure that they are fed and bathed and dressed, right? We need to make sure when you do all of those things, everything else becomes so much better. And so we want to make sure that they're doing those things and that they're safe while that's happening. But then we really, really want to create these meaningful activities and give them a life worth living. And so I encourage everybody to really take a look at, there are some wonderful resources out there. Obviously, I'm happy to be a resource. Anybody can reach out to me at any time, and I would be happy to answer any questions. But I highly recommend the Parkinson's Foundation, the American Parkinson's Disease Association, the Michael J. Fox Foundation, the National Council on Aging. Really use credible resources. I joke around a little bit. I have Parkinsons.com probably isn't the best resource. You really want to make sure you're going to places where the information is credible. Mayo Clinic is another great one. The Brian Grant Foundation, like I mentioned. So those are the resources that I highly recommend. And I think with that, I'm going to pause and open it up for any questions.
Thank you so much, Melissa. Wow, you provided so much good information and so many great little tidbits. So yes, it is the time for the Q&A. And if you have any questions for Melissa, please type out your questions now. We already have a few in the queue. Melissa, one question. Do they see behavioral changes in patients who have had MRI-focused ultrasound treatment?
So behavioral changes in terms of, MRI-focused ultrasound addresses the motor symptoms. So typically, it helps with tremor. So in terms of behavior changes, I haven't heard of that. It really just helps minimize the tremor.
Okay. And you had mentioned yoga. What does yoga do for you? What's it good for?
It's great for flexibility.
Mm-hmm. Okay. And then another question, have you looked into MCT oil?
So I'm not a doctor. And so any supplements that anybody wishes to take with their Cinemet should absolutely be asked to their doctor to make sure that it is safe and that the doctor is okay with that. I do know that MCT oil has been found to be helpful for brain health, but again, beyond that, I'm really not qualified to answer that question if somebody with Parkinson's should be on it.
Mm-hmm. Another question. I have heard about patients having flooring that looks like stairs to trick their brain into walking better. Have you had any experience with that?
I have not. What I can tell you is movements that enforce big, giant steps are incredibly effective. And so remember, everything gets slower and smaller. So people with Parkinson's disease, they think when they are taking, you and I would be taking giant steps. Like when we were kids and we would say like, mother, may I take 3 giant steps? That is what we want people with Parkinson's disease to do. They think they're taking huge giant steps, but in actuality, they're taking normal size steps because their normal size steps are much smaller. And so the emphasis is really on big giant movements, both walking, arm swinging, all of those things are critical.
Mm-hmm. Going back to exercise, and this is kind of my question, and then I'll provide the question from the audience. Like, in what ways is exercise, how does it make things better? Why does it help? And then my question from a member of the audience, where would I find studies showing that exercise slows the progression of Parkinson's?
So you can go to any credible source and search exercise and Parkinson's disease. Every movement disorder specialist will tell you exercise slows the progression. Go to the Rocksteady Boxing website and it will explain to you why that program is so effective. But essentially, getting your heart rate up, don't have to be out of breath. But getting your heart rate up, continuing to move, right? It's all related to dopamine, which is what's missing. And so the exercise can help stimulate some of that dopamine reaction. And that is what slows the progression of the disease.
It's fascinating. And just another related question about, I missed it. It had said something about what exercises specifically, which you did go over in the presentation, but maybe just run through it again real fast.
Yeah, absolutely. So look, any exercise counts. Again, there are specific exercise programs designed for people with Parkinson's. So that's Rocksteady Boxing, that's Dance for PD. Tai Chi, like I said, is great for balance. Yoga is great for flexibility. Water exercise is safe. We really just want people to move. So even walking, stationary biking, chair exercises, sit to stand, any movement counts. Gardening, housework, right? Running a back, that counts. We just want people to move.
Mm-hmm. Here's another question, a little bit different topic. Ideas for Parkinson's support group topics.
So that's a great question for me. So I facilitate 8 Parkinson's support groups a month, and people do ask all the time, what do we talk about? And my answer is, we talk about whatever you want to talk about. I honestly never go in with an agenda, but I can tell you the topics that we address. So we talk a lot about medications. We talk a lot about sleep challenges. We talk a lot about who has found a new movement disorder specialist because the one that they were using is no longer taking their insurance or they're no longer happy with them. Sometimes I bring in guest speakers to talk about new medications or occupational therapy. We talk about medical marijuana. But then, last week we talked about traveling with Parkinson's disease. And there's a bunch of folks in one of my groups who are frequent travelers. And so they were able to share some helpful tips on navigating the airport, navigating a cruise ship, those kinds of things. It really is. I mean, one time we talked about, there was a gentleman on my virtual support group and his grandchildren came to visit and he was really struggling because he decided that one of his grandchildren was just a brat and really too difficult to be around. And so he just needed the support of his friends, right, from his support group. We didn't even talk about Parkinson's disease for the first 40 minutes. He really just needed some help getting through feeling this way about his grandchildren. So any topic is on the table for support groups.
Yeah. Can you explain what home health can do specifically for Parkinson's patients?
Yeah. So home health that's skilled. So PTOT speech. Home care, which is what I do, that's non-medical private duty home care. So we assist with activities of daily living. We also can help with those meaningful activities. So when a caregiver goes into a home, obviously, like I said, safety and security, number one priority, bathing, dressing, feeding, med reminders. But then also, I had a client who had Parkinson's disease, and he was a musician, not by trade, but as a hobby. And so one of the things that we used to do was he joined a chorus through an organization. We used to take him to his chorus practice. We had the caregiver make a playlist on their phone and play his favorite music from back in the day. Another example, so my grandfather had Parkinson's disease. We did not know back then everything we know now. I wish we did. Life would have been quite different for him and for my grandmother. But he was a cartographer in the Army. And so one of the things, had we known, right, we could have had a caregiver take him to the library and look at old maps from where he was stationed, right? That's a meaningful activity. And those are the things caregivers can do. Family caregivers or professional caregivers, truthfully.
A very special thank you to Melissa Morante of ComForCare. What an awesome presentation. Please learn more about ComForCare at ComForCare.com. Thank you all so much for tuning into this webinar. You've been a big part of the success today. Thank you for your terrific questions. This is Liza Berger from Ignites.
Thank you, Melissa, for sharing your insights and providing strategies for implementing person-centered Parkinson's care. Listeners, visit ComfortConnections.com to download complimentary resources, view show notes, and access our episodes. You can also subscribe to our podcast on your favorite app. Thank you for listening and helping older adults live the best life possible.